This is Webinar 6 in the Minnesota Drug Diversion Prevention Pathway webinar series, Leadership Guidance for Detecting and Responding to Suspected Diversion. Detecting and responding to suspected diversion involves both upstream monitoring and prevention and downstream response. Historically, leaders believed that they would know, or at least have a strong suspicion, if a staff member was diverting controlled substances. When a person is caught diverting, it is often someone you would not expect. There are a few signs that someone is diverting that cannot also be explained by something else. Changes in behavior can signal an addiction problem, but employees can be having a hard time, burned out, overwhelmed, dealing with a medical, mental health, personal, or family issue. As a leader, it is important to be looking for these signs to take care of your employees, but they must be placed in context with the larger picture. The drug diversion prevention pathway was designed to give leaders a structured way to assess facility process, identify medication and facility vulnerabilities, prioritize interventions, tailor tools in the toolkit, decrease vulnerability to drug diversion, and by doing so, improve patient safety. The goal of using the pathway in your organization is to implement sustainable, intentional systems that make it more difficult to divert. Another tool for upstream detection of diversion is the Controlled Substance Administration Review. This tool can also be used downstream when you have signs that diversion may be happening in your facility. Collecting and reviewing every administration of a controlled substance over a period of time, weeks, or months, is a mechanism to improve safety and to determine if there are aberrant administration patterns among your nurses. The process will vary based on your organization and facility resources. But typically, administration data is either collected via EHR report or manually from administration counts or logs. The data is then placed in a spreadsheet and compared in several ways via the sort feature. It is somewhat time-intensive, but it can often give a leader a good understanding of controlled substance administration patterns. From the employee side, we look to see if an employee has far more controlled substance administration than his or her peers. Is a specific nurse responsible for most of the emergency controlled substance administrations within an area? From the resident side, is there a resident who is only receiving controlled substance doses from a single employee? Is there a resident who generally doesn't have pain who is receiving controlled substance doses? Do nurses who work in the same neighborhood and on the same shift have similar administration patterns? Are administration patterns different based on the cognitive level of residents? As an example, is an employee documenting more controlled substance administration to residents with cognitive deficits? Is there a resident who receives a larger dose than usual, or 2 doses together from a specific nurse? Is there a nurse whose controlled substance administration is higher with a specific drug? Are nurses rating pain levels fairly consistently for specific residents? Does this change based on prescription of controlled substances? Often, diverting clinicians' pain assessments will align with their peers for residents with no controlled substances ordered, but will be significantly different for residents with controlled substances. Across the review, the biggest question you will ask is, does this make sense? Using your knowledge of your residents and the facility, you will be able to figure out the majority of the administrations. A resident may have had a fall, dressing changes, a gout flare-up, surgery, or a week of high anxiety. What you will probably end up with is a handful of administrations that don't make sense. You can then go to the charting or to the nurse and figure out what is going on. You may end up with a few nurses to keep an eye on, Or you may end up with someone whose administration patterns don't make any sense. In these cases, you will make a decision about how to manage the situation with the new information that you have. So we've looked at the upstream side of things, but what do you do when you have an incident, a report, or a suspicion that someone is diverting controlled substances in your facility? The ability to complete a thorough diversion investigation when there is a suspicion of diversion is an important skill for long-term care leaders. Ensuring available evidence is gathered systematically and is readily available helps with HR action, law enforcement, regulatory bodies, and surveyors whose work helps to keep residents safe. The drug diversion prevention pathway recommends that someone is assigned and trained to complete an investigation in every facility 24 hours per day. There should be no delay in completing investigations. When a controlled substance is missing, employees should not be allowed to leave the facility until the assigned leader gives permission. Completing proactive staff education can help employees know how to report and what to expect when a suspected diversion event has occurred. Staff need to know what to do if counts do not reconcile, if they have suspicion involving another team member, or if they are worried about a resident. Staff should escalate all controlled substance discrepancies that cannot be immediately resolved to an individual who is trained to complete and document a formal investigation. If there is a concern about an individual, either an employee or a resident, staff should know the process that is in place for them to report this. If you are a nurse and the count doesn't reconcile, both nurses who are counting look for what could have happened. Even if they figure out what has happened, the nurse who is staying needs to document it, usually via an occurrence report, and it needs to be reviewed by leadership. If the nurses cannot figure out what happened, it becomes a suspected diversion event that must be reported immediately. If a controlled substance is missing, employees in that neighborhood or unit are not allowed to leave the facility until the assigned leader gives permission. The Drug Diversion Prevention Pathway Project has a toolkit with resources for employee education. The third webinar in this series is a plug-and-play education module for employees. If there's a suspected diversion event, or if there are controlled substances that are unaccounted for, an investigation should be launched immediately. If an individual is suspected of diverting medication, they need to be put on administrative leave until the investigation is complete. They should not continue to care for residents. The first step in an investigation is to summarize what you know. Write a brief summary of the situation in story form, so anyone reading it can put the investigation pieces together into a cohesive whole. Then gather documentation. Make photocopies or run reports of all controlled substance counts, resident documentation, or other pertinent information. Keep these copies in a safe place. After that, interview all pertinent individuals, including staff, residents, and family. Documentation should be reviewed with the person who was interviewed and signed when feasible. Documentation can be in the form of a witness statement, where an individual writes down their version of events. Witness statements and interviews should be dated and signed. The Drug Diversion Prevention Pathway Toolkit contains an investigation template that can be used to ensure the collection of all pertinent details. It is available at www.apiaryconsulting.com under the Project Links tab. It is important to note that the investigation template has a place to check off that a task was done on the right-hand side, and a place to fill in information on the left. It is not intended to be self-contained. As an example, it has sections for incident summaries and witness statements. These will need to be attached as part of the investigation packet. Reconstruct the timeline as well as you can. Sometimes we won't know all of the details, but keep track of the pieces that you do know. Identify what you believe has happened. What do you think was the reason the diversion happened? How did it affect residents? Identify the involved parts of the chain of custody. Were there contributing factors? This could be policy and process problems, training and education issues, or issues with hiring practices or staffing. The facility information area can be helpful if the incident is investigated by the state or law enforcement. In state investigations, the alleged perpetrator, or AP, is anyone who is suspected of diversion. If there is someone who is suspected of diversion or who has confessed to diverting, having some details about that person is helpful. There may be additional information you have collected. Each of these sections are to ensure that you have documented or put together information if it is available. Law enforcement should be contacted if controlled substances are missing and cannot be accounted for. In most cases, use the non-emergency line. Missing controlled substances should also trigger an incident report to the state. If a licensed or certified individual is suspected of controlled substance diversion and either resigns or is terminated during the investigation, facility leadership should report the case to the professional board that governs the individual's license. This will ensure there is follow-up, keeping someone from diverting controlled substances at multiple facilities. The facility needs to have a secure location identified for investigation evidence. This includes photocopies of all documentation at the time of the report to ensure documentation tampering does not occur, physically securing evidence, and signed witness statements or interviews. Facilities should complete a root cause analysis of all medication investigations, even if they were able to find the medication or resolve the discrepancy. This creates a proactive medication management environment. After the investigation is complete, stakeholders should schedule a time to look at the incident and assess facility process to see what systems can be improved to decrease risk to residents or improve process for staff. Facilities should use their internal process or can use the Minnesota Department of Health online root cause analysis toolkit to complete this analysis. This RCA meeting should be documented, and changes in process should be communicated across the organization. Process changes, education, implementation, and ongoing monitoring should be documented.